All right, I have the pleasure of opening the festivities. It's really a delight to be here for the launch of Victor Roy's superb new book. Books are incredibly hard to write, and I feel like as somebody who has published a fair amount, it often feels anticlimactic once it actually comes out. So it's great to have an occasion to really celebrate and to be able to do it here in person with all of you. So thanks so much for coming. So I'll just introduce everybody and then turn it over to Victor for a brief introduction, and then I'll do some comments along with Lenore Palladino. So Victor is a physician and sociologist whose research focuses on the political economy of innovation and equitable access to care and treatment. He's currently a postdoctoral fellow here at the Yale School of Medicine in the National Clinician Scholars Program. This book project started with his doctoral research in sociology and political economy at the University of Cambridge. And between then and now, he earned his medical degree from Northwestern and completed his residency in family medicine during the pandemic at the Boston Medical Center. So I've been really eagerly awaiting this book since I heard Victor present on it some years ago, because as I'll say a little bit more about during my comments, it really was kind of a shot out of the blue for me to hear about this project, because it's really exceptionally original in the way that it brings a bunch of different strands and ideas together. So I'm somebody who's worked on access to medicines issues in the pharmaceutical industry for decades now. I'm much older than I look. In law schools, the debate's been really centered around patents and intellectual property, which is, of course, an important part of the story that we'll hear today. But it really hasn't featured conversations, and this is true in the health policy world too. It hasn't featured more wide-ranging conversations about how the way we structure corporations in law and policy and the way financialization works, those shape the industry. And so those are key parts of the story that we're going to hear today. And they're really, really interesting and raise new possible interventions in these issues, which of course are so urgent for all of us. And part of why I'm very excited for today is that we were able to get Lenore Palladino to come and be a commentator along with myself. Lenore is the perfect person to do this. She's an assistant professor of economics and public policy at the University of Massachusetts Amherst and a fellow at the Roosevelt Institute. She does research and policy advocacy focused on the political economy of corporations and the implications of shareholder primacy on the US economy. She has a PhD in economics from the New School for Social Research and a JD from Fordham University School of Law. So without further ado, then I'm going to invite Victor up and he'll talk for maybe 15, 20 minutes, providing an overview of the book. And then Lenore and I will provide some comments, and then we'll be able to turn it over to Q&A. And also we've got a great group joining us online. Please just put your questions in the chat and we'll try to kind of go back and forth so you also have an opportunity to engage. All right, Victor, please.
Thanks so much, Amy. Thank you for helping organize this event, and Lenore also for engaging with this work. Let me actually, first, before actually going into thank yous, let me share the slides here on Zoom. Share screen. So thank you everyone for being here in person and virtually over Zoom. Thanks Amy for that introduction, and for you and Lenore for engaging in this work. I also want to thank the Law and Political Economy groups and the Global Health Justice Partnership for helping organize this event and all the work that went to it. I've long admired the work of both groups, and it's an honor to be able to share this project and this launch with these groups. This project started, as Amy mentioned, almost a decade ago. And between the twists and turns of doctoral work and my medical training, there are a lot of people to thank, some of them in the room and also on Zoom. You can read the acknowledgements, so I'll say thank you again. So I come to this project as a doctor and also as a systems thinker trained in sociology. I began my doctoral studies nearly a decade ago after about a decade after the height of the global HIV access, global HIV movement and the access to medicines movement that really taught us so many lessons about the systems that prevented us from treating people equitably. But I was interested in why, even after all of these lessons, a lot of our most innovative, the fruits of our innovation continue to fail to reach some of our most vulnerable patients. And in this, the case of hepatitis C loomed large. My research took me far afield from where I expected, to corporate finance, to Wall Street, and to their influence on public health. I hope some of the questions that the book raises might provoke ideas and questions for you too across the different sets of challenges you might be wrestling with, trying to learn more about. So what I want to do in the next 20 or so minutes is, I'm going to have to use this. Let's see. Okay, good. Okay. Is to set the scene for the book, share 3 frames that help understand the main arguments in the book, and then have a discussion with all of you. So we're going to start in June of 2015. I'm in a clinic in South Central Los Angeles as part of my field research. And here, this federally qualified health center has identified and diagnosed 70 patients that have hepatitis C. Now, this is about a year after new curative treatments for the disease have been launched. And there's hope in the air because these treatments might offer something that these patients haven't been able to benefit from. But there's also frustration and anger because only one person at this point had been able to gain access to treatment. To understand what was at play here, I need to tell you a little bit about hepatitis C and the launch of these new treatments and the controversies that ensued. So the condition affects a lot of people. About 2.4 million here in the US are infected. In 2012, at the time, in a time before COVID, it was actually the leading infectious killer. Globally, according to 2016 statistics from the WHO, about 70 million people are affected. And this primarily affects structurally marginalized populations and people who use drugs. It's transmitted via the blood in the US through injecting drug use. It injures the liver over time. This is not something that happens in days, but over the course of years, it can lead to the sequelae of cirrhosis, of liver failure, cancer, and ultimately death. And what's important to know is that the old treatments for hepatitis C were really toxic. They required weekly injections of a treatment called interferon, and they had no guarantee of cure. Now, in 2013 and 2014, Gilead Sciences launches these new treatments. The main compound behind them is sofosbuvir, and these sofosbuvir-based medicines are approved as part of an all-oral regimen in October of 2014, and they offer cure rates north of 90%. And they're an all-oral regimen, not requiring any more injections. Now, this applause for science was quickly met with consternation over the price of these treatments. Gilead Sciences set them north of $90,000 for a 3-month regimen. They quickly became dubbed the $1,000 a day pill. Now, as part of the context you should know, and part of Gilead's thinking was that the prior treatments already cost $70,000 or so and offered, like I said, far fewer health benefits. Another reference point to note, however, is that these treatments cost about $100 to manufacture in the factory. Now, when you multiply that price point by the number of people that could benefit, this posed a financial challenge for health systems. And this is where health systems responded by, in many cases, restricting access to treatment. So in the US, this led to the state Medicaid programs, for example, only offering treatment to people with more advanced stages of liver disease. In 2014, only 1% of people were treated at a cost, 2.4% of people were treated for the Medicaid program at a cost of about $1 billion. Medicare spent $14 billion on these treatments in just 2 years after their launch. And this led to the US Senate Finance Committee launching an investigation into Gilead's prices. Now, as all this was happening, there was an interesting argument that was being advanced by industry and health experts that the high prices reflect the value that curative treatments bring to society in the form of increased in the form of savings downstream, as well as just the increased health that comes from curative treatments. This led to headlines like this in Vox. Each of these hepatitis C pills cost $1,000. It's actually a great deal. This echoed a line from the pharmaceutical industry. Gilead remarked, price is the wrong subject, value should be the discussion. So part of what I was wrestling with is that this entire line of argument and this framing around value, I thought was fascinating and puzzling and even troubling, because this would mean that our best treatments would actually, by definition, be some of our most expensive ones. And so I was trying to understand what was driving this framing around pricing and evaluations of new medicines. And as I explored this question, I kept on coming back to sociology and political economy literature that I saw absent in the business and health policy debates. And that related to the rising power of the financial sector and financial logics over our economy and society. This dynamic has been called financialization in the sociological and economic literature. And what is it? For the purposes of this talk, I'm just going to distill it down to 2 points. And I think Lenore will probably get into it a little bit more. But as Greta Krippner documented in her book, Capitalizing on Crisis, there's a series of political decisions and shifts from the late 1960s into the 80s that really enabled the rise of financial institutions, markets, and logics to gain power in our economy. And one of the concrete consequences was that the financial sector starts constituting a much larger share of the overall profits in our economy. And there's a second consequence here, is that finance also morphs businesses themselves. As described by sociologists and business journalists, the growth of the financial sector helped shape a situation in which businesses turned to accumulating quick earnings, dubbed quarterly capitalism, via financial maneuvers that they then directed to Wall Street rather than reinvesting in wages, worker training, and for the purpose of this conversation, in R&D. Now, there's been less investigation into precisely how these dynamics of finance have shaped the making and the pricing and the valuation of medicines, and how that impacts public health. And that's the question at the heart of this book and the black box I sought to open. Yep, we good? Oh, it wasn't advancing. Oh, okay, great. So really briefly, what the book does is I develop a sociological case study of these treatments. I trace the science, the R&D, and the policy struggle around these treatments between the mid-90s and the 2010s, studying the key actors involved, and I followed the knowledge and the money in the process. This is all informed by theoretical sources that I'll touch on, and data sources that I'll highlight here, 2 of which I'll highlight, which I triangulated between. One is earnings calls transcripts between Gilead and Wall Street between 2013 and 2016. They give us a lot of insight into a lot of the financial dynamics at play. And then I had the privilege of being able to review 1,500 pages of internal corporate documents because the US Senate investigation put it into the public domain. So to understand some of the key claims around this book, I want to go through 3 frames that help unpack the way that financialization here operates: assets, value, and power. So assets, what I'm interested here is in how knowledge is turned into financial assets. And I'm going to start with the company here that develops sofosbuvir. They have the name right in their, the word right in their name, Pharmasset. It's a common story. It would be a familiar story of a publicly funded scientist, in this case at Emory and the VA in Atlanta, launches the company in the late 90s, built off of this publicly funded research. A team later on develops sofosbuvir. They're able to raise $100 million in venture capital and through an IPO on the NASDAQ stock exchange and enter the compound into clinical trials. And in 2011, by that point, the company had spent about $270 million in total research and development. There was no products or revenues, just the promise of this compound. But the company was worth $8 billion. So I think this valuation can teach us something if we connect it to the literature on assets. And here I'm interested in a group of science and technology scholars who draw on the work of the economist Thorstein Veblen, who is studying corporate power at the beginning of the 20th century. And what Veblen does is describe assets, both in terms of tangible assets, which are something like a house, or intangible assets, in this case, knowledge. And the ways in which this gets turned into financially valuable property is something a group of more contemporary scholars have studied. And they describe this process as assetization, the ways in which the transformation of something into a future earning stream occurs. And of course, in the case of sofosbuvir and this story, what we're interested in is the political, legal, and economic processes that turn a compound into a patent, into a financial asset. And one way to understand assets is to actually compare them with commodities. So commodities, they derive their value from an exchange process. A government will pay a company something in order to be able to receive treatments, for example. Assets derive their value from ownership over a future earnings stream. So this could be something like intellectual property over vaccine knowledge. Now this leads to interesting demand logics. So typically when there's high demand for a commodity, that will attract more producers, that will lead to a price drop over time. Think about cell phones, for example. But in the area of pharmaceuticals, where we have assets that are politically and legally made to be scarce, increased demand leads to higher valuations. Think about asset bubbles. Now, let's come back to the $8 billion valuation here. Part of where the value comes from, of course, is actually public investment in assets, in some of our most valuable assets, in terms of our technological breakthroughs. And this is described by Mariana Mazzucato in her book, The Entrepreneurial State, in which she describes the ways in which public investment is critical to a lot of biomedical innovation. We saw this with COVID vaccines, and certainly it's the case with, as a document in the book, behind these sofosbuvir-based treatments. And it's something that venture capitalists appreciate. This is one of the key venture capitalists behind Pharmasset in their Series B, sharing that due to NIH funding now also going towards programs that demonstrate commercial potential, our startups are much further along by the time we invest, even though they might be straight out of academia. And of course, there's a whole political and legal process that converts this socially produced knowledge into financially valuable assets that venture capitalists can then value. Now, there's another piece to this $8 billion evaluation, and that's where drug prices come in, which is that each generation of treatment sets the pricing floor for the next launch and the next set of treatments. And this creates this promise of a future earnings stream that produces a lot of the speculation through which different financial actors can accumulate capital. This definitely happened in hepatitis C. This is just data from the Swiss market, but you could replicate this in the US as well, where if you look at each generation of treatment represented by the bars and the cure rates along the x-axis, as we got better treatments, the prices correspondingly went up. So this study found that for every 1% increase in cure rate, the prices went up by about $1,000. Now, by 2011, the prices for the existing treatments for hepatitis C were already north of $50,000. And Wall Street's anticipation that better treatments would be able to garner even higher prices were part of that $8 billion valuation that Pharmasset had. Now, of course, this does lead to significant mobilization of capital, but it's important to note that a fraction of this actually goes into investment in innovation. And a lot of this is actually attracts financial actors that are just trading on the share price to accumulate wins. So one of the key actors in this case is QVT, a hedge fund that stakes out positions in a lot of these hepatitis C companies. And that money goes to the executive of this hedge fund, a Yale law graduate. And he graces the cover of Forbes with a subheader here. In 6 months, he turned 5 million into 3 billion, and he has plans to do it again and again. So part of the point here is that assets are a really lucrative value proposition. And the founder of Pharmasset knew this from the very beginning. He says, I coined the name. It's actually pharmaceutical assets. And the idea was to create assets that could be sold to pharmaceutical companies. That was the initial business plan. So now I want to turn to the frame of value, because it helps us understand who's on the hunt for these assets and where the value in the innovation process goes. So I want to start with the company here in the story, Gilead Sciences, that ultimately ends up controlling the asset of sofosbuvir. In 2011, by all definitions of a company, they're pretty successful. They've got $8 billion of revenue annually on their HIV treatments. They've got $10 billion of cash on hand, and their profit margins exceed 30% of the last 3 years off of these HIV meds. But Wall Street isn't happy because they're not showing the growth that they expect. So this is a headline, or this is a statement in a Bloomberg piece. As its earlier galloping growth begins to slow, investors are starting to wonder what Gilead plans to do for a second act. And this relates, and to understand this dynamic, I want to talk a little bit about the structural crisis of growth in a financialized economy. And here I'll draw on 2 pieces of literature. One is about maximizing shareholder value from Bill Lazonick and Mary O'Sullivan, where they trace the way maximizing shareholder value, in other words, delivering growth to shareholders, becomes the primary focus of corporations during the 70s and 80s. And part of the challenge here is that for companies like Gilead, pharmaceutical companies, they're expected to grow at a rate of about 10% annually. And the point here is that it's not just about profits, it's about a growth in profits. And this brings me to Sundar Rajan's work in Pharmacracy, where he describes how this structural mandate around growth actually positions pharmaceutical companies to become less R&D firms, but actually specialists in acquisitions and regulatory approval because of the long time horizons it takes to develop treatments. Now, Gilead's executives have this self-conception, right? They say in their earnings calls, we typically like things where we can have an impact on phase 3 and then accelerate those products either into the approval process or greater indications after the approval process. Now, in late 2011, Gilead views Pharmasset as an attractive target because Pharmasset's already brought their compounds to promising phase 2 trials. They're entering into phase 3, and they can combine sofosbuvir, they believe, with some of their internal compounds to form an all-oral regimen, just like they have with HIV. So the company bets $11 billion to buy the company. And this has nothing to do with R&D costs. It has everything to do with what Wall Street thinks that health systems may be willing to pay in the future for these treatments, at this point north of $70,000. I'm going to fast forward here on the value question. Gilead makes $46 billion on these treatments in the first 3 years of their launch. And what I want to look at is, where does this value go? A huge proportion of their earnings goes to buybacks and dividends, over $30 billion. Compare that to $11 billion on research and development. Now, share buybacks, just a minute on that, they're a tactic that's used across American corporations after this was made legal by an SEC rule change in the 1980s, where companies essentially buy their own stocks to increase the value of the remaining ones. And it's a way of trying to boost share value. Over the last 10 years, just a study put out in December, pharmaceutical industries listed on the S&P 500, they spent 13% more on buybacks and dividends than research and development. So I want to tie this to the conversation around value and the work of economist Mariana Mazzucato in her book, The Value of Everything, where she traces the ways in which financial markets are actually vehicles to extract tremendous value and wealth from the economy. And so in doing this, she makes the statement that we have made it easier for some to call themselves value creators and in the process extract value. And so this actually brings me to my final frame, which is about power. And it's a certain kind of power, hegemony, that I think actually connects to Mariana Mazzucato's point here about value. And here I'll draw on Sundar Rajan again in his book Pharmacracy, where he describes not so much the overt coercive political power that money and politics can have, but more this idea of hegemony in the ways that financial logics of value become almost commonsensical, and they are naturalized into the way things are. In this case, normalizing high drug prices. And look at how this happens in the case of hepatitis C. When these drugs are launched right in the period afterwards, there's a series of studies that point to how cost effective they are because of the significant benefits they provide. And there's an emerging consensus in the health policy literature. This is just a quote from Mark Roberts at Pittsburgh. The most important thing to remember about cost effectiveness is that something that is really expensive can still be cost effective if it is really, really effective. And these drugs are really, really effective. Now, to make sense of this whole dynamic, I draw on Joseph Dumet's work. He's a science and technology scholar. He's written a book called Drugs for Life, How Pharmaceutical Companies Define Our Health, where he looks at the post-war era of biomedicine and the emergence of these really important tools of contemporary biomedicine, long-term clinical studies of natural history of disease, clinical trials, clinical epidemiology that is able to aggregate the benefit of treatments at a population level, and then pharmacoeconomic studies that can impute an economic value on this. And what he argues is that we have a shift in what we treat from felt illness to an abstracted statistical illness. And the idea here is that we're able to put an economic value on this downstream population health benefit. And what's interesting here is that these are obviously pillars of contemporary biomedicine, and there's a rationality contained in this that is really important, which is that we should spend our money more on better treatments than worse ones. But what's interesting is how this is able to be appropriated into this process to actually naturalize these really high drug prices and how pharmaceutical companies use this. So this is an earnings call where Wall Street, as Gilead is facing political pressure around the drug prices, they reassure Wall Street. There are publications out there, not by Gilead, but by respected people in the field who can start these conversations in a more academic, collegial way, putting all of this together into a bigger pharmacoeconomic argument. Just a few months later, in the Harvard Business Review, health economists, citing their industry funding, prominent ones at USC and Harvard, put out a piece called "It's Easier to Measure the Cost of Healthcare Than Its Value," in which they make this very argument that, and they call the arguments around pricing good theater, but missing the point on the value that these treatments provide, and that trying to lower prices would hurt future generations and deplete innovation. Now, I want to juxtapose that with what was happening in the public health conversation, where in 2016, the National Academy of Medicine convened an expert group to try and come up with a plan to deal with viral hepatitis. And their conclusion is that though eliminating the public health problem at hepatitis C is feasible, the group concluded that it would require near universal access to treatment, something that appears unfeasible given the current pricing and policy environment. Now, there's a much larger context around what happens since that time that I'm happy to talk about, and the political responses that this all engenders. And there are solutions that emerge from that debate. But what I think is important to understand, and the point that I try and make in the book, is that value becomes untethered from maximizing access and public health, and instead fastened to the financial markets and logics of growth, speculation, and extraction. And so I'll come back to that clinic in June of 2015. There's almost 70 patients here waiting for their treatment. Meanwhile, billions are being bought on the stock market through companies are buying their own stock on the stock market. Federal and state officials are struggling to deal with addressing the underlying policies that have allowed this to happen. And in the clinic, there's post-it papers of new workflows that already overburdened clinic workers are trying to develop to figure out how they can get across the barriers that stand in the way between their patients and these hepatitis C treatments. So I think part of our work, and I'll end here, is that to try and denaturalize some of the taken for granted terms and systems that allow this to be a kind of status quo. And so I'll end with this quote from Ursula Le Guin, which is the author who shares the idea that the exercise of imagination is dangerous to those who profit from the way things are because it has the power to show that the way things are is not permanent, not necessary, not universal, and not necessary. And she ends by stating that having that real though limited power to put established institutions into question, imaginative literature, here speaking as an author, also has the responsibility of power. And I would argue that imaginative political economy, research, organizing, policymaking also have a responsibility of power. But this requires a kind of moral imagination that is within our reach if we dare to nurture it. Thank you.
Come on up. Great. I'm going to start us off with a few comments.
On the other side.
Victor, that was a superb tour through what is ultimately just a part of the book. I know that we'll talk some today about there's a last chapter, which is about solutions, which is one of the things I think we'll want to explore more when we get to the kind of Q&A and discussion part. Sort of like, well, how do we fix this? What are some of the alternatives? And maybe at that point, I'll invite Victor to say a little bit about that part of his argument. So I guess you've seen a little bit of why I described the book the way I did as a really significant achievement to sort of change the frame of how we think about overpriced medicines. So probably you're all here because you've heard many times about the problem of overpriced medicines or encountered it in your own lives as physicians, as caregivers, as patients. It's an enormous problem. And I think part of what Victor's book really is helping us do is see how the way that we think about the right way to price medicines is in deep conflict with other kind of moral imperatives to care for one another and to care for ourselves. And this is a historically contingent kind of process. This isn't how medicines were always priced, right? So Victor's really tracing a change in logic from a kind of industrial era, a pharma industry, where they talked about recovering their R&D costs, for example. That was how they talked about what it meant to price a medicine. And where, when we started in the HIV days, looking over here, Greg, right, activists in the HIV days, we've had inflation since then, but, we thought exorbitant costs were in the tens of thousands of dollars, right, a $30,000 a year treatment. And we now see treatments at $2.5 million a year, right, or for a course of treatment, right? And all of that, I think, is really beautifully described in this kind of incredibly revealing detail in Victor's book, right? So how did we turn, like what needed to change in our minds to move from a model where, prices, we're at one scale, like of the exponent, and now they're on another, right? And I think he builds a really convincing account that financialization is a big part of this, and the change of mindset in the industry, that what they were doing was not producing and investing in cures for health, but they were managing financial assets, and they shouldn't leave money on the table. And I think that sort of the introduction of these ideas from finance, right? And then, in fact, very specifically, how you show the way laws and ideas about, say, shareholder primacy actually encourage corporate behavior, right? We're only in this for 3 years, and then we got to get out, right? And that the biotechs are organized that way. Once when you start looking at what would a fair price for Gilead's drug be, right? You could look at the $100 cost of actually producing the drug, right? Full course of treatment for $100. But of course, that wouldn't factor in what the companies had to spend on producing the drug and developing the drug. A lot of that was paid by the public sector. Victor's book shows that, right? But once Gilead enters the market to buy Pharmasset at $8 billion, right? The fact that nobody spent more than a couple $100 million to develop this drug, that almost becomes irrelevant because now it's this asset and people have spent $10 billion. Now they've at least got to recoup the $10 billion, right? And so the kind of this hyperinflationary pricing gets kind of baked into the background way that the market operates. I think one thing that we should also put on the table, and that you see as a physician, I'm sure, is that there's this deep conflict between the sort of social expectation and even increasingly legal expectations that we have that people will be provided medicine, and then the sort of monopoly, financialized monopoly, that's how we do it, right? Because if you have a right to a medicine and the company has the right to set the price at whatever they want, that's a great recipe for prices that go up essentially forever. And where do they stop? Well, it depends how much you value your life. And for most of us, there isn't a limit to that. There's only a limit to what we can pay, right? And so this is where all of the very sort of rich material that Victor also has in the book about inequality and how, if you think about hepatitis C and who still dies of hepatitis C, including today, right? That's about who doesn't have the money. And even more complexly, who doesn't have power over their insurers, right? Because ultimately what happens when the prices go up like this and everybody wants access is that the people providing the sort of insurers or whoever's negotiating the price basically pits the patients against the companies, and sort of like, well, we'll make it so hard for the patients to get it that we can either get the price down from the company. So we'll tell the companies there'll need to be 3 referrals before, unless you bring the price down, right? So all of this kind of friction is introduced in this system to try to bring the prices down. That's not actually a very coherent or patient-friendly way. And it has deep inequities built into it, right? So that people who don't have a lot of power over their insurers to overcome all of those barriers don't get access. So putting all that on the table, I think Victor's account also really beautifully sets up a set of well, I guess what I would say is it sort of punctures the sort of ideas about markets being these natural things and prices being these natural things. So there's wonderful detail that he didn't get into even here about how when Pharmasset gets sold, like what's the right price for that company? And the estimates are divergent by billions of dollars, right? Because there isn't actually an answer and nobody knew it when they went to invest. And the sort of whole idea that there's a logical, rational way that investment is being planned and that prices are sort of being worked out coherently, like doesn't really make any sense when you scratch the surface and you look actually at what's going on. So I think for those of you in the room interested in sort of law and political economy and the work that we're doing in law schools to sort of talk about how law structures markets and why the conventional stories that kind of really took over inside of law schools about markets being efficient and sending resources the right way and helping us make neutral decisions about where to invest. This kind of detail really helps us see what's wrong with some of those stories in practice. And I hope we'll get a chance to talk more about that. So let me hand it over to Lenore, and then I'll come back and start us off with a couple questions.
Great. Well, thank you so much for having me and Amy for inviting me. Maybe I'll put this down here. No, because I'm going to slide this a little bit. So I have a couple of slides up here on a webpage. Right that way. Great. Thank you. So I'm so excited about this book, and congratulations to Victor, because I'm an economist and I work on issues of corporate finance, but we never connect it to the liver, right? We don't connect questions of corporate power and shareholder primacy enough to our real lived health outcomes and how people are experiencing, the tragedy of hepatitis C and not being able to afford medicine for yourself and your family. We don't make these connections enough. So I'm really excited about the book. I think it's excellent and a really important read, not only for those of you who are interested in health issues, that I don't think I've ever been in at a medical school event before, so it's fun for me, but for those of us who are interested in corporate finance and corporate power. What I wanted to do, and we'll see if it can't get put up, that's totally fine. I'll just make a couple comments and I can share them later. I thought capitalizing the cure offers the right diagnosis of what ails the US economy. And that's my attempt at a joke, so you can laugh if you would like. I'll just read the quote, one of the quotes that I pulled out about corporate financialization being at the heart of what's wrong with healthcare. The financialization of biomedicine has meant that the primary strategy of the system is to extract financial value through speculation on health assets in stock markets. Now, my work has been about expanding that idea to the entire economy. How has corporate financialization meant that we've gone from an economy that's focused on production to an economy that's focused on value extraction? And I work very much in the tradition of the economists that you mentioned, Bill Lazonick and Mariana Mazzucato. So I thought I would just add a little bit, again, because I know nothing about the liver, or I don't even know how to pronounce the medicine that's referenced in the book, so I'm learning that. I would say a few things about, first, shareholder primacy, and then what we might do about it, with, I think, this idea that's very much in line with what you discuss in the book about how part of our work, I think, as academics is to pull back from what has been accepted as common sense, right? And so the idea that corporations operate to maximize shareholder value, the idea that that's their sole purpose, has become so dominant in our society that we forget that we need to look at the corporation as a site of production and see that we have the right as a democratic society to set the rules around, under which it operates, right? We actually can do that. So I'll just make a couple quick comments about that. So I have a lot of text here, and I can make it available to anybody who's interested, but I'm just going to make a couple of quick points. What is shareholder primacy, or as you've referred to it as financialization? Sometimes we call it corporate financialization. It's the legal and economic framework of corporate governance that claims that the sole purpose of corporate activity is to maximize wealth for shareholders, and thus that executives and boards of directors should prioritize increasing share prices above all else. And I think you've outlined how this works incredibly well in the book. In my work, what I try to do is pull out how it's a completely incorrect way of understanding what corporations actually do, right? It's not a theory of production. It's simply a theory of allocation. It answers the political economy question of who should have power over decision-making within corporations by saying it should be shareholders, and who should control distribution of corporate profits, also shareholders, and enshrines this answer into corporate law. And it's based on this really false idea that shareholders are the only ones that contribute anything of value to the corporation, that they're the only ones that take risk. Everyone else, employees, customers, the public, we all have some kind of fixed contract vis-a-vis the corporation, and therefore we should have no role in its decision-making. I could talk for hours about the flaws of this theory, and I'm writing a book about it, so maybe I can come back and talk about it when the book is out. But the key to shareholder primacy really is that it's not a theory at all about production, how corporations actually produce what we need in society, right? How they meet the needs of our economy. So I'll just say one other point about this. A foundational problem of shareholder primacy is that we forget that an alternate way to understand what it's doing is simply asserting the right of the rich to stay wealthy, right? Or to get richer in the case of, Gilead and its shareholders, right? It's simply a model that has enshrined the operating of the economy to continue to benefit the very, very small percentage of wealthy white households who hold the vast majority of corporate equity. It has nothing to do with the type of economy that we might actually want to see. So let me just make a couple points. I think there's really two areas of reform that are essential, not only for dealing with the problems of financialization in healthcare, but for dealing with the harms of shareholder primacy and corporate financialization for our whole economy. One is in the realm of corporate and financial law, right? So we have, as those of you who are at the law school know, we have in Delaware corporate law and in a lot of our financial laws and regulations, we have enshrined the power of shareholders, right? But these are policies that are historically actually pretty contingent. In the progressive era, the continuation of the practice of incorporation at the state level was a product of political negotiations. It wasn't some natural law that must always be the case. The idea that the board of directors is solely responsible to shareholders, again, is one of the policies that we can look at reforming in order to really grapple with these problems of shareholder primacy. The other area of sort of hegemonic pulling back we need to do is to disentangle the relationship that we have in our society between retirement security and shareholder primacy. So if you engage at all or you listen to the debates about why we need practices like stock buybacks, why we need to keep so much of our economic and financial policy making focused on propping up the stock market rather than doing the kinds of policies that might actually benefit your everyday household, the reason is, well, we are all shareholders. We live in some kind of shareholder democracy. This is one of those myths that, like so many of the, I think, myths that you pull out so effectively in the book, has become, really deeply rooted, even in those of us who see ourselves as, progressives or working in progressive economic policymaking. And it's just an incorrect way to understand what creates retirement security. And there's a lot of policymaking that we can do to actually address the core problems of people having dignified retirement without necessarily entrenching that retirement security in the the daily ups and downs of the stock market. So I think the book is incredibly rich in institutional detail, which I am always hungry for as an economist and really love. And I think what it does is gives us one story that helps us understand a lot of the broader harms that we're dealing with today in the US economy and helps motivate some of the solutions that we can explore going forward. So thanks for the opportunity, and I'm excited for the conversation.
All right, I'm going to do, it's 1 o'clock and I know some folks have class, so feel free to gather your things if you need to leave, and we'll go on, as long as we can. We have the room until 1:30, so happy to turn it over to your questions in just a minute. I think I wanted to, so it's interesting, right? We have a really kind of mixed audience here. And I think, Victor, your book crosses over these audiences. So I'm having a little bit of a professor's instinct and wanting to draw you guys out a little bit more on this connection between shareholder value and the liver, right? Because it's complicated. These are terrains that people usually they might know the liver, they don't know the shareholder thing, or vice versa, right? So I guess maybe I wanted to ask you, maybe both of you could do this. So talk a little bit about how, I guess I took the shareholder value thing here. What it really means is that Gilead wants to pump its stock price up no matter how. And Lenore's talking about, there's a whole theory about how this benefits the world, because high stock prices means great 401ks and retirement. And that's problematic in a lot of ways. But maybe just walk us through a little bit, how did they get to the high share prices? And why does that not actually help us get new drugs out there? Because in the background here, I think a skeptic would come to this and say, well, look, what they're doing is they're putting all this money into drug development. And isn't that awesome? I mean, $10 billion, fine, but think about the value of your liver. Your liver is, worth $1 trillion. And if you add up all the livers, you know what I'm saying. And this is exactly the kind of story we got with the COVID vaccine, where, people were saying there's no amount too much to pay for the COVID vaccine because, COVID's shutting down our economy. And so $1 trillion, how about 2 trillion, 5 trillion, basically the size of our economy, regardless of the size of the federal budget, is that the amount we should be willing to pay? So yeah, do you want to say a little bit maybe about connecting those dots here? How did Gilead get to the sort of drive its share prices up, and why didn't that benefit patients?
Yeah, so it's interesting, I think. So I'll try and connect the liver to Gilead's share price, actually in an interesting and maybe way that would be surprising here, is that ultimately the share price is what? It's just a representation of the potential for future growth. That's what a share price is. Is this company going to grow in the future? And so in the first few years after these treatments launch, their share price goes from the 40s to the 120s. And part of what happens here, as I show, is a lot of the value that they are able to extract from the process goes directly to shareholders. And part of the premise, of course, the myth around a lot of this that we hear about is that, oh, this money is going back into research and development and going to go to new treatments. But what's actually really interesting in the case of Hep C is this was a curative treatment. And so actually by curing the liver of the virus, what ended up happening is that the share price starts dropping. So this is a company that makes $62 billion in 2015 and 2016 in Hep C. And while it's making $62 billion, actually Wall Street is not happy because of the fact that it's a curative treatment, and the idea that they can continue to grow in the future endlessly is something that's obviated by the very fact that its asset is reducing their hopeful future customer base. And what happens in the dialogue between Wall Street and Gilead is very much Gilead trying to turn Wall Street's attention to, hey, look, we've got these HIV treatments over here. Remember, these are chronic treatments that people have to take for the rest of their life. And this is what we're still planning to build our long-term growth strategy on. And so this idea that a lot of the health economists that were justifying the price were saying, well, if we were able to pay more, we're going to continue to get more curative treatments. And what we see here actually is that, Wall Street is kind of conditioning Gilead and saying, actually, watch it on the curative treatments. We like your chronic business model. And that's actually what's going to be critical for their future long-term growth. And it very much comes out in chapter 3 of the book.
I'll just add one bit to that, because as somebody who's worked on HIV, what you describe after that is this is when Gilead starts toying around, not a new breakthrough in HIV treatment, much less a cure, but toying around with how do we basically tweak something so that even though our patent's expiring on that drug, we can create a tiny different version, switch everybody over to that, right? So what they do in response is this kind of non-innovation, but just to try to, again, like, how do you capture the asset stream, that's still there and make it grow, even though we're not really doing much of that's innovative. It led to a big antitrust suit, all kinds of things that have ensued, but reassured the shareholder or the investor analysts maybe.
Yeah, I found that to be one of the really illuminating sort of moments for me in the book, knowing, again, nothing about actual drug production, medication production. So I'll add maybe just 2 points. And I think that I'm so excited to hear you talking about what I have called the myth that shareholders are investors. So I'll just shout out the LPE blog. I wrote a piece that I think came out last April with that title, The Myth That Shareholders Are Investors. And I think, as you just said, that's really one of the harms, not only, of course, in pharma, but across our economy. It's this idea that the more we see shareholder trading happening, that somehow that'll increase the productive capacity of our economy. And I think in this current moment of industrial policymaking that really the Biden administration is spearheading, we're seeing finally a public recognition that improving productive capacity in the economy requires public investment, requires real resources, requires workers, right? It's not about the speed at which shares are trading on the financial markets. And so I think being really strategic about making a separation between what shareholding is and how it's trading affects financial markets and affects the broader economy is essential in terms of sort of dealing with some of these problems. And then I'll just say a second point, what are share prices? I would say they're whatever a buyer of that share is willing to pay at that particular time. So another myth, another sort of hegemonic problem that I think the LPE Project is dealing with, and sort of all of us in pluralist or non-orthodox economics are dealing with, is the myth that we have some kind of perfect competition in our markets, including in financial markets, right? There is no, I don't believe there's any perfectly competitive market out there in the economy. And I think that share prices are determined so frequently by behavioral expectations by corporate financial practices like stock buybacks, which is simply a way to legally manipulate the market price of your own stock, and ultimately that are determined by, these days, the interests of the financial institutions that are the ones out there trading shares. So we have a real, I think, another one of those myths that we have to pull back to really understand the purpose of shareholding in general.
I guess I'll just say, and then I want to come to your questions briefly, that there is a wonderful last chapter, as I mentioned, which talks about the possibility of public options for drug development as a way of sort of putting a different logic in motion that would prioritize public health needs and would then also better be able to control the price of medicines. And so just to put that on the table, if you'd like to take us in that direction, we could talk some more about that, as well as all the very rich material that's already before us. So I'd be happy to, I think Corinne and Raul are going to let me know if there's questions online. And then also maybe we'll start with a question from the room. Do you want me to take the, can we keep the queue? Okay, great. We'll start in the back.
Hey.
So I'm trying to know what you think of the pieces of the Inflation Reduction Act and whether they will in any way help, and whether they will in fact have any sort of problematic positive effect.
I should say what's in it.
Yeah, the Inflation Reduction Act that was passed in August. There's a bunch of different drug pricing provisions in it. I think the key pieces that I'll point to here is, for the first time, really enabling Medicare to do drug pricing negotiation. The key catch here, of course, is that it doesn't start until a drug has already been on the market, has been approved for 9 years. And negotiations could start at 7 years, and I think it's like 11 years for biologics, in terms of when the negotiation starts. And what's interesting is, right, that the kind of reasoning behind this, in part, of course, it's driven by political lobbying and the interests of the pharmaceutical industry, but at least the plausible reason that's given is, well, we need the drug companies to be able to recoup their R&D costs. It's written into the law. And it won't take more than a few years to recoup any R&D costs, if they're probably recouping in the first months on some of these treatments. And so I think that doesn't really deal with the challenge of launch prices for new treatments. And I think we're going to continue to see this kind of playbook, right, of, publicly funded origins of innovation, financialized, and then given a value price that is used as kind of the justification for a certain price. And I think, we're going to deal with this in, a lot of different therapeutic areas. And I don't think the IRA will deal with, will really address that. But I think that the fact that drug pricing negotiation is now on the table, creates, I think, more possibilities, right, in the next generations of how we, think about policy, and we can learn from that trial. I think the only other thing I'd say is, I believe part of the legislation also forces companies to basically give to rebate Medicare money if they increase the prices on a given drug faster than the rate of inflation. So part of what actually happens that I describe more in the book is that it's not just that each price sets the floor for the next one, is that in between those years, oftentimes drug companies will also raise the price so that it's, by the time you get to the next launch, it's not just what the price was 5 years ago on this generation of treatment, they've also raised the price. And that, I think, at least maybe reduces some of the inflationary pressure. So it's an incremental strategy, but I think it does do something.
Yes, thank you. Just me.
Yeah, that was, yeah.
Thanks. It seems to me that what allows a pharmaceutical company to charge that much is that there are for these drugs, whether it's private insurance, so if the pharma are laws or regulations that stop them doing that. And my question is, why isn't the Sherman Act applicable here? The antitrust. Why?
How would the lawyers answer that one?
Seems to me this monopoly is clear. Now it's a monopoly worldwide too. And then you look at the demographics, most of the FC patients are overseas and not so prosperous countries. It seems to me that the pharma is making most of the money in America, in the US.
Context.
Because no society can afford these prices. So
I'll say a little bit about you're a lawyer too, though, so you should chime in on this one. So, again, I think you could look back historically and people who worked on antitrust saw patents as monopolies and thought that the antitrust laws really should have implications. But part of what happened in the same time as we're getting the shareholder primacy arguments, all of these arguments kind of brought in from Chicago School of Economics into law schools, changed the way we interpreted these laws, and antitrust laws are a big example of that. So why do we have so much corporate consolidation today? Because again, ideas about how antitrust laws should work, they were very similar to the way that the shareholder value thing worked in corporate law. Said, essentially, there can't, when firms get bigger, it's because there's efficiencies of scale, not because, they are actually dominating their rivals. And so there's kind of all these stories told that changed the way antitrust law operated. And one thing that we saw at the intersection of antitrust law and intellectual property law is that antitrust law really backed off and said, well, patents are there to give incentives for innovation. They are, well, maybe they're not really monopolies because maybe they don't really give market power. So there's a lot of just saying, well, these aren't real monopolies, or saying, well, we should just let the intellectual property laws deal with whether or not to give a patent, as opposed to having the antitrust laws come in and say you're abusing your patent. And so the antitrust laws have really retreated from really having much at all to say about the abuse of monopoly when the basis of it is something like a patent. That's a problem in part because inside the patent office also some of these same ideas get going and they start saying, well, we have to make sure we give lots and lots of patents because we need innovation. And so, oh, you want a patent for a new salt form? How about an isomer, an enantiomer? How about a new dosage form? Or how about and so they start giving all these new kinds of patents to the point where new drugs today, the most successful ones will have 135 patents on them, right? Even though it's really one chemical compound that's really the critical innovation. And so that's a sort of probably too long version of how changes so there isn't much that the antitrust laws can do unless we, I think, start to understand them a little bit differently, which is why people have really instead relied upon things like a legislative, something you might think of as a public utility, right? Let's regulate the rates because this is a monopoly and it needs to be rate regulated. So let's regulate price. Something on the global side?
Yeah, I think I'll just make a quick point about I think you had the implication there that there's kind of like a territorial strategy around this, right? Which is high income countries can afford this and X countries can't. And I think one of the interesting bits with hepatitis C, but plays out differently for different treatments, is that first we're seeing actually high-income countries are now dealing with the challenge and struggling with the challenge of high-priced new treatments, particularly for ones where there's a large patient population. So even in Europe, where they have government negotiation of pricing, initially there was a big challenge with how to deal with the numbers multiplied by the price point, and there was rationing even there. They were able to, I think, get through some of those problems quicker than we have in the US in a more fragmented system. Gilead did license this treatment to generic companies in India that were able to export this to some 100+ low-income countries at a price point of $1,000 per treatment course. And that was based on their strategy from HIV treatments that they, did after a ton of activism and organizing and political pressure. And so we see, though, that didn't happen with COVID vaccines at all. And I think what's interesting is that where a lot of these companies are going is the middle income strategy. So the New York Times article that was just published 2 days ago, looking at Novartis in Brazil, a lot of these companies are looking at middle income countries as places that they can really go to generate a lot of accumulation, where they're not going to license treatments to generic producers, but where there are enough, where there's enough wealth maybe that they can generate some earnings. But this is, of course, going to stress these governments and their budgets significantly. In the case of the New York Times article, I think it was like 250 patients for this really rare form of a pediatric disease. And it's $1 million a treatment. So Brazil is paying $250 million for it, which is obviously going to create opportunity costs for other things that they could have spent that money on that would also improve health.
I've written about the Brazilian laws in that case, and I think one thing to be aware of is people who are interested in health and health advocacy is that that's being driven by the fact that there's a right to health in the Constitution in Brazil. And so you can go to court and say, I have a right to this medicine, but it's never been understood as having implications for the political economy of medicine. So we've got to also have the courts and the legal system and advocates engaged in understanding why prices are what they are, denaturalizing it. It's not $1 million because it costs $1 million to develop or make, and challenging that, or we'll never be able to kind of get to a better place with respect both access and building a structural health system that protects people more broadly. Okay, I have a couple more questions. Was there a question in the? Did you want to go to the? Okay, so why don't I come to you guys and.
Chat. I'd be curious to hear more about how pricing happens. Top of my mind is the frustrating pricing and licensing negotiations between Pfizer and Chinese authorities for Paxlovid, but I'd love to hear thoughts related to any example or in a general sense.
So I think, there's a lot of variation in how this plays out. So I'll lean back on the Hep C example, where in this case, governments used different kinds of powers to do different kinds of deals. In Egypt, this was a country that had the highest prevalence of Hep C because of past public health programs that actually led to the iatrogenic spread of the disease there. And in that country, the government just didn't grant Gilead a patent. And so that actually forced Gilead to the negotiating table, and they were able to get a much lower price. Whereas a country like, another example is Australia, they had a really interesting example that I think I want to highlight, where they basically said, we have about $1 billion Australian dollars that we can devote to this program. And so they offered it as an upfront lump sum payment in return for access to the medications. And that's been dubbed the Netflix model, where governments basically subscribe to treatments. And this was trialed in Louisiana in the US and Washington with some success. And there's some a discussion about actually trying to create in the US like a national subscription model that would be used to kind of negotiate with drug companies, where they could get upfront lump sum payments in return for access to the medicines.
I mean, I suppose it's just worth putting on the table. You mentioned earlier that there's agreements like the World Trade Organization's agreement on intellectual property that require countries to offer patents for medicines. And so these negotiations are happening against a backdrop where, again, only over the last 20 or so years have countries had to provide patents on medicines. Many countries didn't used to because of the implications that you couldn't buy a generic. Right? For a new medicine, and so it would radically drive the price up. But it's the desire for growth in emerging economies that led to companies pressuring the US government and European governments to put these into treaties. So now you have patents. So now you have to deal with the same monopoly dynamic in low and middle income countries. And so they start to look more like ours, with the exception of having a healthcare system and insurance system that can spread the costs. Right? Okay, so I think, Greg, you had a question?
How cost effectiveness is included in your slides, because we do cost effectiveness. And there's a version of it from Farmer which is associated with a sense of absolute value, right? But cost effectiveness is always compared to what? It's making a comparative assessment of the new Hep C drug versus things that you before. But there's other aspects of cost effectiveness: budget impact analysis, value is an objective, equity instead of total health, equity as a as an objective. And so, but in a lot of these conversations, cost effectiveness collapsed in sort of the official version, which is often that it's justifying those high prices. And it's taken at face value a little bit. There's a weird thing that happens in some of these conversations in which we surrender cost effectiveness as a tool to industry. And I don't think it's actually right on the earth of how the tool works. I'm just curious to see how you were thinking about it, because there's a whole literature out there that you obviously saw in front of you.
No, I think that, I think I was in the book very much looking at the ways in which the pharmaceutical industry appropriated a certain version of it. But it is true that I think even the Institute for Clinical and Economic Review, that's a powerful new group that I think is doing important work around how to value new treatments, has things like budget impact analysis as part of their valuation process, which I think is really crucial. And so I think it's important, science is something that can be used in different ways, but to come up with the versions that have those other values that are very much like baked into it, that posit a very different outcome. So I think it's a really important point to put on the table.
There's a great, relatively recent book called Thinking Like an Economist by an academic named Elizabeth Pop Berman that really discusses how the principles of mainstream economic analysis have jumped the shark really in public policy. That I really resonated with me reading the specific examples in healthcare. So for anyone who's interested in that, I think that would be a really nice complement to your work.
I mean, one thing I think just to say is that there's a disconnect between the way cost benefit is done in some settings, like, in the federal government, and the way it's done in the healthcare setting. And some of this reflects like how important it is exactly how the technology works, right? So if you use it the way Gilead did to say, well, the existing treatment's $80,000, and so ours is better, so it's got to be more than $80,000. And so you're not, connecting this to anything like what was the cost to the company of developing the drug, right? What will be the cost to the healthcare system or to access if we price the drug at $80,000, such that we'll get, we'll spend $50 billion and still have treated a very small percentage of the people who have this disease, right? So if you disconnect it from any real analysis and grappling with what the inputs are, you get these catastrophic kind of results. Gustavo.
For some of the economics of drug development and alternatives to that, I have increasing disagreements with a friend at Stanford Business School, as you can imagine, who sort of insists on the necessity of this like massive remuneration to drive innovation. And I'd love some talking points that results in these incredibly like twisted market outcomes, and what might be a better and more equitable way to produce these.
I would say read The Entrepreneurial State by Mariana Mazzucato, which was mentioned in the talk. I think that is a incredibly rich, detailed story, not only of, it does have some of the story of how public investment has been critical in pharma, but also in all kinds of sectors in the economy. I think would give you many, many talking points. I don't know if your friend will be convinced, but.
Yeah, I mean, I think Victor's book has a lot of great detail on this too, right? I mean, from the forensic, right? How much did it cost to actually develop sofosbuvir, which is they make them deliberately hard to say. The generic names are deliberately hard to say, I believe, because they want you to use Sovaldi, which is easy to rolls off the tongue. So wait, how much did it cost you? There's sort of a little bit of contention because some of this information has not been audited, for example, but a couple $100 million, right?
Mm-hmm. Yeah, and the US government funding behind this, the Portal Research Group, who did a great patent analysis where they traced public funding, it was about $60 million of public funding. And then it's interesting, Pharmaset's actual line item for that PSI 7977, which is the sofosbuvir compound, was about 62.4 million. So it's kind of public funding, private funding, and then Gilead comes in with the clinical trials that do cost a lot of money, and that phase 3.
And there's another great detail in your book, which I like to recount to people, which is that the Moderna, we call it the Moderna vaccine. It's actually NIH and Moderna developed together, right? The development costs were almost entirely paid for by the federal government. And it's got no relationship. The price is about to quadruple. That's got no relationship to the way it's going to be priced over the long term, right? So one part is the disconnect between those things. And I think there's a lot of rich detail on that in Victor's book. There's a lot of other things to put on the table also, which is sort of what are some of the malformations of driving innovation in this way, right? People don't share things with one another. They sit on things, or they don't develop compounds that might have that, that might not profit them as much as others. And they develop small adjustments to their existing compounds because that's less risky than really innovative research. So there's like a whole host of other things that the book can also point you to. I think Anne, you had a question, right?
Yeah, very similar question, but just to follow up, if like so much of what's driving is public investment, like what are the tools, whether legal or political, to guard the value? Like how would you prevent a private company from just sort of like piggybacking off of what was largely public investment?
I think this is like a $1 billion question around, and it's really important. Mariana Mazzucato has also written a lot about and thought, and I'm sure you both will have more to say about kind of the idea of conditionalities, that public investment should come with certain conditions. And in general, over the last 15 or 20 years, we've kind of pulled back any notion of doing that because of the fear that will kind of scare off private investment. And I think that was a big problem with the COVID vaccine case. The big kind of alternative that's been talked about is not a novel idea in the book, but I kind of develop it further, is that we should just actually have a public option where that the government takes on actually the production of medicines in certain essential cases, and is able to produce it and offer it at a cost that is just a little bit above the cost of manufacturing, and would provide an important kind of model and strategy in response to kind of the financialization of what I describe in the book.
Yeah, it's a great question. And I've been writing actually a bunch lately about exactly this question of conditionalities in industrial policymaking, sort of not just about the more general public investment, but this current moment where we have billions and maybe even trillions of dollars of loans and loan guarantees that are going to go out the door. And I think that there's two kinds. There's putting conditions in place to stop negative value extraction. So for example, we can put clear limits around things like stock buybacks and executive compensation. And for an example, right now, actually in the CHIPS and Science Act, which now is going through the rulemaking process in the Department of Commerce, they're actually doing a really great job of putting a lot of these conditions in place. It can be done. It just needs the political will. And then I think what is, sort of more exciting and harder to imagine politically is to have more proactive public engagement in the actual benefits of the public investment that's going forward. So we can explore things like public equity stakes in companies, not only in moments of bailouts and crises, but actually in proactive moments when we're making major investments for the future productivity and sustainability of our economy in a moment of a major economic transition that we're going through. Why aren't we going to benefit as the public from that major moment of public investment? We can put those kinds of positive conditions in the rules. It just requires a lot of political will, and that's the challenge.
I think we've just got time for one more quick question.
In fair warning, you're talking to someone who used to be a reporter and who's a qualitative sociologist by training, and so I'm going to ask you about stories. And that's because that's one of the things I think is so excellent about this book, is that it tells such a cogent, clear story that anyone can actually understand. And so, like baked into a bunch of these questions, in my view, is like it's like begging for another case, like another case that looms large of innovation that happens in a non-financialized area to like almost be a story that you could tell about the opposite. So, something that comes to my mind as an emphatic non-expert is thinking about innovations that happen in places with nationalized healthcare systems. So like, there's a ton of medical innovation that happens in the UK, even though it's obvious that like the way it's going to get paid for is fundamentally different. And I wonder if there is an encapsulated story that you have that might stick in our minds a little bit more as to an alternative that actually happens.
Good question, Andrew. I think in the last 20 or 30 years, honestly, like the model that I've described is kind of the prevailing one. And so I think and Amy and you can, Lenore can jump in, you know, you've got the open science kind of model around the flu vaccine. There's not a ton of great examples, I think, in terms of really the kind of like totally definancialized model of how to do this.
Right. What's interesting is you've got a lot of models where the public does everything up until very late, but then the company comes in. And so to some extent, those are great models, right? And we can say, you know, the development of lots of HIV drugs, in fact, the development of the Hep C drug, right? This actually happened a lot, all of the critical science until relatively late happened in the public sector. But bringing it all the way to market, I think you have to go back further in time and look at things like that, like Walter Reed Military, you know, Hospital, which created, in fact, many, and all the way till the end, drugs for tropical diseases. You know, sort of downside of that narrative is it was to allow the U.S. military to safely go, you know, pillage and plunder around the world. But shows certainly that it can be done. But I think, you know, the entrepreneurial state is either focused a lot on early stage stuff or on applications outside of pharma. And just to say, I think one of the complexities of this is bundling the model together. When you think about the financialization of the industry, if you have this public option competing with pharma has endless buckets of cash. And so when they see a promising candidate, they come in and they buy it up to make sure that they monopolize that last stage. And so thinking through exactly how the public can actually kind of, in some sense, compete against an industry that operates in this financialized way is tricky, I think. But certainly one of the, sort of end on a positive note, you know, we just had the passage of something called ARPA-H, designed on the DARPA model, with the thought that we hope, many of us hope, it will actually do all the way to market. It's not guaranteed that it will, and provide some of those more contemporary, positive, alternative models to show that this can in fact be done.
Because like open source software is so immense.
Sure.
You can, so like there are some little pockets of
Right. And part of what Victor mentioned is, you know, I wrote a much too long paper about the influenza vaccine and how all of the science that has gone into over these many years, figuring out which gathering the viruses, figuring out which to put into the vaccine is all done by public science. And so we do have examples. They don't exactly look like blockbuster drugs, but we do have lots of examples. Yeah. I'm afraid we really have to stop given the time, but thanks so much to all